In patients with aortic stenosis, important features on general examination include age, evidence of prior surgery, and signs of heart failure. Degenerative calcific disease is the most common cause in older patients, while younger patients may have a bicuspid valve. Examining the hands and arms, focus on stigmata of infective endocarditis and signs of anemia. Patients with severe aortic stenosis may have a narrow pulse pressure, less than 40 millimeters of mercury, due to reduced stroke volume and restricted flow across the valve. They may also have a small volume pulse on palpation. Now focus on the patient's eyes for anemic conjunctival pallor. Ask the patient to open their mouth. Examine the mouth for quality of dentition. Examine the carotid arteries one side at a time, first palpating, then auscultating. In patients with severe aortic stenosis, the carotid arterial pulse typically has a delayed and plateaued peak, decreased amplitude, and gradual downslope, known as pulsus parvus etardis. The murmur of severe aortic stenosis may radiate to the carotids. Inspect the thorax for evidence of prior valve replacement and the presence of a pacemaker. The apex beat in aortic stenosis is classically pressure-loaded, which is forceful and focal due to left ventricular hypertrophy. A palpable thrill, usually at the right upper sternal border, is an important sign of severity in aortic stenosis. Move on to auscultation. Aortic stenosis can affect the heart sounds in the following ways: a soft S2 due to failure of opposition of severely calcified valve leaflets, a paradoxical split S2 due to delayed aortic valve closure, presence of S4 due to atrial contraction against low compliance ventricle. The murmur of aortic stenosis is a harsh, crescendo-decrescendo, early systolic ejection murmur over right upper sternal border with radiation to the carotid arteries and sometimes to the apex of the heart. Later peaking murmurs imply more severe disease. Note, a localized ejection systolic murmur in the aortic area with no radiation or thrill may be due to aortic sclerosis, leaflet thickening without significant hemodynamic effects. Signs to indicate severe aortic stenosis are a plateau pulse in the carotid arteries related to slow flow of blood through the valve, narrow pulse pressure due to reduced stroke volume of blood through the valve, the presence of a thrill over the aortic valve region as you feel the high pressure from blood through the valve, a split-second heart sound due to delayed left ventricular emptying, a late and long peak of murmur, a fourth heart sound due to forceful atrial contraction into a hypertrophied left ventricle, signs of left ventricular failure. We'll now go through a few maneuvers to accentuate any murmurs or irregularities. The murmur is accentuated by maneuvers that increase preload, such as squatting or expiration, and post-extrasystole. The murmur is diminished by maneuvers that decreases preload, such as Valsalva, and those that increases afterload, such as hand grip. The Valsalva maneuver will accentuate the murmur of hypertrophic obstructive cardiomyopathy because the obstruction is below the level of the valve in the left ventricular outflow tract, and Valsalva makes the left ventricular cavity smaller by reducing preload and cardiac filling. Listen to the lungs for any pleural effusions or crackles suggesting left heart failure. When summarizing your findings, consider the difference between aortic sclerosis, stenosis, and subvalvular obstruction due to hypertrophic cardiomyopathy. Consider the signs of severity. And remember, if you get a wink, keep it professional at all times.